visible.
Okay. So perioperative care of the elderly. First of all, sometimes they ask you about what is the definition of geriatric age. Anybody above 65 are called elderly or geriatric population, and the aging is associated with progressive loss of functional reserve of all organ systems. And the onset and extent of these changes vary from person to person. So we always call people for two things. One is they can be uh, uh, chronological age, and the other thing is they have a biological age. So some people, as you say, this lady 92 years have been preserved very well. As per she was ambulant, she did not have much problem, and
Yes.
she has been going on with routine work. So biologically, she may be much younger compared to her chronological age. So
Yes.
the interaction of underlying diseases, limited organ reserve, and stress of the perioperative period are these things which affect their well-being. So mechanisms of aging, there are two things: programmed or biological clock theory, which is mainly genetic in nature, and error theories, where this environmental damage leads to impaired function and progressive decline. But both of them usually overlap each other. So there are two theories. One is biological clock theory, and other is the error theory. And changes that happen in the nervous system, physiological changes are there, and pathological changes will happen because of aging. Physiological decline in memory, decline in gray and white matter, reduction in area of epidural space. This is a very important point from our point of view, and increased permeability of dura and decreased CSF. That is the reason why we are able to give a smaller volume and achieve a higher level of drop because of this change in the central nervous system. Pathological, there is increased incidence of delirium, dementia, Alzheimer's disease, and Parkinson's. Changes in the CVS, physiological, decrease in number of myocytes, decrease in contractility power, decrease sensitivity to beta adrenergic stimulation. Sometimes when you give atropine also, the heart rate may not go up. And increase in vascular stiffness, and pathological changes. Diastolic heart failure is more common because the myocardium becomes so stiff it doesn't relax. And heart hypertension with LVH is more common. Ischemic heart disease is also more common. Cardiomyopathies are common. And valvular heart disease like AS and mitral valve calcification are also very common because of aging. Respiratory system, there is a decreased response to hypoxia and hypercarbia. There is loss of elastic reticle, decreased surfactant leading to increase in compliance. And VC, vital capacity also decreases. And closing capacity usually exceeds FRC, leading to leaking mismatch. Pathological changes are increase in pulmonary arterial pressure, hypoxic pulmonary vasoconstriction is blunted, so the shunting mechanism happens more. Increase incidence of aspiration due to decrease in vital capacity. And renal, there is a loss of renal cortical mass by 30% at 80 years of age. So there is a decrease in GFR, decrease in renal blood flow of 10% per decade of life. So loss of ability to concentrate or dilute urine, decreased capacity to conserve sodium. That is why they become hyponatremic more easily. And decreased thirst response can lead to dehydration. In the hepatic physiological changes, there is a decrease in liver volume, then there is a decrease in blood flow to the liver, enzymatic reactions are slow. So the pathology will be decreased rate of metabolism of drugs, prolonged duration or increased sensitivity, especially to narcotics and sedative drugs. Endocrine changes, atrophy of endocrine glands results in decrease in secretion of insulin, thyroxine, renin aldosterone, and testosterone. So the pathology will be reduced secretion of hormones, lead to diabetes, hypothyroidism, electrolyte imbalance, and impotence. Coming to hematology, decreased activity of bone marrow leads to lower production of red blood cells, white cells, and immune cells, which all lead to decrease in function of bone marrow, causes anemia because there is a reduced RBC, increased susceptibility to infection, and increased incidence of cancer also. So, the pathology will be decreased response to hypoxia, hypercarbia, decreased respiratory function, decreased So geriatric syndromes which are important: osteoporosis, aging of musculoskeletal system, loss of skeletal muscle mass, increase in body fat with less subcutaneous fat, osteoporosis which is asymptomatic and result in fractures. So this is how the bone looks in a normal condition and an osteoporotic patient. Osteoarthritis can affect many of the joints and also lead to chronic pain. So you can see the narrowing of joint space and ability to make decisions and give consent. Advanced directives are difficult. The age-related diseases like hypertension, diabetes, dementia, Parkinson's, malignancy are there. And the atypical presentation of acute illness or exacerbation can be challenging. And cognitive deficits are postoperative emergence and preoperative morbidity. Polypharmacy can lead to drug interactions. The goal in the management of geriatric patients is to get into the preoperative level, that is as is where is condition. As they have come, you should bring them back. They should not have any change and they should have activities of daily living. You should inquire about that. And frailty, this is a common theory question that is asked. Frailty index refers to loss of physical reserve, which includes mobility, muscle weakness, poor exercise tolerance, unstable balance, and body composition like weight loss and malnutrition. The other factors which need assessment are nutrition. Some of them have a depression before the age of 65. Immobility can cause hypovolemia, ventricular atrophy, and dehydration associated with hypernatremia and infection like pneumonia and UTI. Hypothermia can cause cardiac ischemia and angina. And you must always assess the risk benefit ratio. Four factors which you should consider are: one is age, the second is physiological status and coexisting disease, three is surgery, whether it is elective or emergent, and type of surgery. So preoperative functional status of the patient is very important to assess how the patient will behave post-operatively. And optimization can all patient for elective surgery should be optimized to their best. And control of comorbidity is very important. And improving the pulmonary function with chest physiotherapy is very important. Adequate hydration and clear instructions regarding daily medications, what they have been taking, whether it can be stopped or continued. That should be the very important instruction. Understanding the factors that influence the pharmacological response will be plasma protein binding, body content, drug metabolism, pharmacodynamics, all these things which happen. Coming to plasma protein, main plasma protein is albumin, as you all know, and other protein is alpha 1 acid glycoprotein. So when the levels decrease with age, there is a more free fraction. So the patient will have exaggerated response if you don't titrate and correctly give the dose. And body content composition changes like this: decrease in lean body mass, increase in body fat causes increase in volume of distribution for drugs and potential for prolonged effect, and decrease in total body water causes smaller central compartment and increased serum concentration after bolus administration of drugs. And drug metabolism alters because hepatic enzymatic activity is reduced and the clearance by renal system is also reduced. And number of receptors and their sensitivity is altered. So always go for a lesser dosage, start with a lesser dosage and give incremental doses so that you don't overload the patient and rush with the bolus dose. And compensatory or reflex responses may be blunted. The pharmacodynamics, the distribution, metabolism, clearance are all affected. Hydrophilic drugs will have a higher plasma level due to decreased body water, whereas lipophilic drugs will have a higher volume of distribution but a prolonged duration of action. The cardiac and circulatory status also will determine the onset of action. So when you give an IV induction agent, because of the slow circulation time, it will take time for the effect to come on. So don't rush too much taking the eyelash reflex or anything. Wait for adequate time. Even the small dose will be, you will be able to induce the patient. Advantages of regional, uh, there is a reduced thromboembolic event, reduced confusion, reduced postoperative respiratory problem, and also it causes less blood loss, and endocrine response to surgery is also very minimal. Advantages of monitoring the cylinder during carotid or TURP type of surgeries is more easy when you do it in the regional. And disadvantages are difficulty in positioning, especially for central neuroclear blockade, increase in the height even with small volumes. That is why always old age is a very low small volume which can decrease to repeated because of low CSF which we saw earlier. And the greater hypotension and hypothermia is another problem. Anticoagulation drug usage to be stopped well in advance. And GA, avoid opioid premedication. Pre-oxygenation is essential. Airway assessment for mask ventilation and laryngoscopy to be done correctly. Like a case like this is totally hidden to us. If they have benches for both upper and lower ear, it is better to make them wear that so that you will get a better mask fit. And all IV drugs to be titrated and administered slowly. Avoid high airway pressure, use of inhalational agents and sedatives and muscle relaxants. Avoid hypothermia, adequate hydration and blood loss replacement, and the early resumption of usage of spectacles, steering aid, and walker. These are all the things sometimes cause them become agitated and delirious in the post-op. And careful monitoring EKG, lead-2 and V5 to detect ischemia, pulse oximetry, CT or invasive in major surgeries, PPCO2, temperature monitoring, neuromuscular monitoring, urine output and risk monitoring to assess the depth. And postoperative delirium and cognitive dysfunction is quite prevalent. One of the common questions they may ask you, and we can remember the mnemonic delirium OP for this. The drug usage, when a new drug is introduced or dose is adjusted, the electrolyte imbalance. Commonly, hyponatremia is more common than hypernatremia, and lack of drugs like withdrawal of benzodiazepine. Some patients are used to taking alprazolam 0.25 or zero point 0.5 for years in there, otherwise they don't get sleep. You suddenly stop that, they become agitated. And infection, UTI or respiratory infection is one of the causes for the delirium. Reduced sensory input like blindness, deafness, or darkness, and intracranial, sometimes stroke or bleeding, meningitis, all these things may be the cause for delirium. And urinary retention or fecal impaction, myocardial ischemia, dysrhythmia, heart failure. So all these letters in delirium, each one is a threat. And lastly, OP stands for oxygen lack and pain. So these are all the things that we have to remember for the causes of delirium in the elderly. And management continues with ambulation, prevention of DVT, resumption of oral intake, chest physiotherapy, breathing exercise, resumption of medications during pre-op, and the early discharge to make them feel at home. Okay, so these are all the things that we have to remember with geriatric anesthesia. The main reason for showing this is to remember all the changes in geriatric patients, because if you get a patient like this so old for your examination, you are likely to be asked all these questions. And the second part thing that all about the valvular problem, how to manage that is another thing that we have to remember. Okay, very good. And then you have done well. Excellent.